So Michael Carter will be our first speaker. He is the director of the Center for Research in Healthcare Engineering and a professor in the Department of Industrial Engineering at the U of T. His research uses mathematic models and computer simulation to understand resource allocation and policy issues. So with no further ado, we're going to ask Michael to come up. Thank you.
My name is Mike Carter, and I've been at the U of T in industrial engineering in systems engineering for about 30 years. And about 20 years ago, I got involved with a project in healthcare, and I realized just how bad things were. And actually, they're a lot better today than they were 20 years ago, I got to tell you. We are making progress. However, and virtually nobody was doing anything of the kind of things that are happening today. So I decided to devote myself to it. And I think I've had close to 200 students who have done projects and things over the last 20 years. I'm pretty sure it's close to 100 people who have been hired in healthcare in Toronto. Most of the hospitals now have industrial engineering people working in the hospital. At any rate, so what I wanted to do, and very quickly to go through this, is I wanted to just show you a few examples. I've got, at the moment, we in the center, we've got 5 full-time staff. I have 14 graduate students. Dion has half a dozen. Tim Chan has a bunch. And Mark Chignall has a bunch. So we have quite a strong group working in healthcare and working with the industry. And just wanted to give you some ideas just on the simulation side. We do other things too, but on the simulation side. And I picked an old example. So this one, just to show you an old example of how we use simulation. 1993, so Children's Hospital, CHEO, the VP of nursing called me, and she said, I've got a problem. It's a pediatric hospital, 50,000 visits to their emergency department. And the problem was that about 50% of the patients who came to the emergency department at CHEO had to wait longer than an hour to see a doc. This is sitting in the waiting room. And about 20% of them had to wait longer than 2 hours just to see a doc. And they didn't really see this as being a medical problem because the kids have been triaged, so it was sort of the runny noses, right, that are waiting for a long time. It was a real serious emergency you were in. But she felt that it was a real PR issue. A lot of people waiting a long time to see a doc and a lot of nervous patients. And so she went to her staff, and they came back with 11 suggestions for how to fix things. Now, some of the suggestions are very good. One of the suggestions was we should put windows on the waiting room so they can see just how darn busy we are back here. Hello. One of the other suggestions was let's put video games in the waiting room. Now, the kids don't care. They won't notice how long they're waiting. The parents are still frustrated. And another suggestion was to put in a fast-track clinic. And in 1993, that was quite a novel idea. If you've just got a runny nose, let's just send you to a nurse and give you an aspirin, send you home. And they actually did that. At any rate, so we looked at that, and we actually wound up building a simulation model for how people go through. But in the process of building our simulation model, we asked them, tell us about your arrival rate at the hospital. Like, how many patients are you getting per hour? And people think of emergency departments as being random. They're not. They're tremendously predictable. I can tell you exactly how many people are going to come through the door between 6 and 7 on a Friday night, right? Like, it is the same pattern every day. And what they noticed was that around 6 o'clock in the evening some days, it started to get real busy, and it stayed that way until about 2 in the morning. Okay? Now, they recognized that they were busier in the evening, so they had shifts set up, so they had 2 doctors working during the day shift, 3 in the evening and 1 at the night shift. Unfortunately, the day shift started at 8, the evening shift started at 4 in the afternoon, and the night shift started at midnight. If you show up at CHEO after midnight, you're going to be there for an awful long time. Okay, because they've been building up a wait list and they're still coming in. So one of the things we suggested was just having staggered wait time. I'm not Mike Carter anymore. Having staggered start times, like just match supply and demand. And it's a completely foreign concept in healthcare. At least it was 20 years ago. We also, based on our simulation results, it took about a year, but they actually got permission from the board to hire a new casualty officer, so a new doc. A second one I wanted to mention just briefly was I was on a committee in Ontario 2007. Valerie Zellermeyer is head of operations at St. Mike's Hospital, and Valerie chaired a committee with, this is one of Alan Hudson's committees for reducing wait times, on surgical process analysis and improvement. I was on the committee. And so they decided that, hospitals could do a lot better job at managing their operating rooms if they had a tool, a simulation tool that could help people decide which doc went on which day and, how that was organized. And if they could understand the impact of it. But unfortunately, they figured only the big ones could afford it, to actually have a simulation model built. So I started thinking about it and saying, I think we could probably build a general model that, a general tool that anybody could use, like, the process of patients coming in and going to operating rooms, et cetera, is pretty straightforward. So you should be able to build a general tool. You just type in, I've got this many operating rooms, this many docs, these are the services they do, this is the case mix, et cetera. So I gave it to a PhD student, Daphne Sneakers. That was 5 years ago. She has done it. My students are just frightened when they hear the things, oh yeah, you can do that. Scare them to death. We did this with partners with Hamilton Health Sciences, with St. Mike's, Mount Sinai. We got a grant from CIHR and HTX, which is the Ontario Health Technology Exchange. And the model goes right back to the doctor's wait list, individual docs with their wait list. They come in, there's pre-op processes, the patients have their operations, they go into an ICU, they go in intensive care, they go into a recovery room, they go into the ward, and they go home. We model individual patients going through the whole system, and then we can do things like playing with all kinds of things like changing the block policies, how the docs are booked, and the way wait lists are managed, and the number of facilities, the number of beds you have in the board, how long people stay alternate level of care after their discharge, how long they stay in the ward, and a whole bunch of things we can play with. So we built it for those 3 hospitals, and then we actually used it at William Osler Hospital, both at the Brampton Civic and the Etobicoke General. We used it in Hamilton Health Science. They're still doing it in Hamilton Health Sciences across the whole hospital. We did it we're now doing it in Saskatchewan. We did it at Victoria Hospital in Prince Albert, which is a long way north and cold right now. We're starting to do it in Saskatoon and Regina, and they plan to do it at all the hospitals in Saskatchewan, and we're just starting to work with Newfoundland. Saskatchewan story is kind of funny because just how they use the tool. The Minister of Health a couple of years ago got up and said that everybody will have surgery within 3 months, okay, for anything, doesn't matter what. And so that's like the 90th percentile, like 90% of people, like 3 months. And so the Victoria Hospital in Prince Albert came back and said, well, right now, our wait time for orthopedic, hip and knee stuff is 6 months, 8 months, and then the 90th percentile, so everybody is like a year and a half. So they said, we can do that, but we need several $1 million because we need another operating room and we need another orthopedic surgeon. The Ministry of Health said, we don't think you're using what you've got now efficiently. Okay? So they weren't sure they wanted to give them the money. So they brought us in, we built the simulation model after a lot of playing back and forth. We're from the ministry, we're here to help you. And after a lot of playing back and forth, we actually convinced them that the model was correct. And based on our model, they actually did get they had to change their processes, the way they were doing things, but they did get the money for the new OR and the new doc. And one of the interesting things that came out of it is we discovered that if they did that and they got their times down, orthopedic would be down by 2014, down to under 3 months wait list. Unfortunately, general surgery was climbing slowly. One of the other things we discovered was they have a surgical ward on one ward that has 32 beds. The surgical ward has an average of 21 medical patients in it every day. Okay, so one of the things we told them is they've got to ring fence their surgical ward. They need more beds than that, or they're not going to be able to do it. So it was very helpful to them, and like I say, they're doing it throughout the rest of the province. I want to show you this. I'm going to just do this one quickly. So this one came out of people may know about Brian Schwartz had a emergency ambulance offload report that they did, a committee, and how can we get ambulances in and out of the hospital faster? And one of the recommendations they came up with was hospitals should know how many beds they need. Hospitals should know how many beds they need. And the logic behind that was that for elective surgery, when a particular doc operates on Monday, I can tell you pretty much exactly how many days his patients are going to stay in the hospital. It's the same week after week. It's the same pattern. And if I move that doc, I'll change the shift, the allocation for beds. On the medical side, I have no idea how many heart attacks are going to show up on a Friday night, but like I said, I can tell you almost exactly how many people are walking the door, and by the way, 17% of them are going to need a bed. So I don't know what the mix of services very well, but I can tell you almost exactly what the demand is for. So you should be able to do that. So after all those many, many iterations, we actually went through and built a model that did that. And we've implemented this in Osler and in Saskatchewan. This is a Regina model. And what we did was we built a simulation model. It's actually, the basis is in Excel. We pushed Excel to its limits. And, but this is showing them on an average weekly basis how many beds you need in the hospital. And this one is for total ward bed demand. And you can see it piles up by Thursday, Friday. That's because docs don't operate on the weekend. The little hash lines are the 90th percentile range on beds, and it's really a very straightforward pattern. And we did it by shift. Midnight census is silly these days because so much happens during the day. So they can use this as a tool for deciding how to allocate their beds. And then the other thing, one other thing we discovered was the green is medical, it's flat. The red is surgical beds, and it goes up during the week. And this is creating big problems. When you start to get tight on Thursday, Friday, you start canceling surgery because you don't have a bed. So one of the things we decided, we could smooth out the demand for beds by shifting docs around. So we built a little model. So here is the before we did the switch for surgical beds, and it's going from about 52 beds on from 47 beds on Monday up to 59 beds on Friday. And what we can do is we can swap docs. We take this doc and move them off this one and that one. So we took their existing surgical schedule. The shaded ones are the ones that moved. We're moving half of the docs. And we came up with this schedule where it's almost flat. Now, the docs aren't going to be happy, but, that's if we can actually reduce the maximum, we reduce cancellations, that increases the doc's salary because they get paid on a fee for service. I threw this model up just for fun, as sort of a final one. Don's looking at me sideways and everything. As a final one here, and this is a model of mental health in Ontario. All right? Mental health is, and what this is, we were looking at, these are the influences and this is something we did for the Ministry of Health recently, and it was the basis of a report that went in. And that little star in the middle, just to give you an idea of what this means. These are the sort of the variables and the drivers and the impact and the performance measures. You take that little bit, and we broke it up into different sectors. Mental health isn't just a health problem; it's a justice problem, education problem, all over the place. And what we were looking at is what are the drivers for manageability of health, mental health, and you see, genetics, situation, job, socioeconomic indicators, etc. So what are the things, and what are the things that the ministry can do to affect mental health? Where can they make investments that's actually going to make a difference? And I'm not going to do the last one. I'm going to quit there. But this one here is a model of the whole healthcare system. Never mind. That's another story for another day. Anyway, thank you very much.